Hello, and welcome to On Becoming a Healer. Here's a phrase: social determinants of health. It's a phrase that appears in new government policies and healthcare guidelines, and certainly in medical education. So if a hospital asks a patient about whether they can pay their bills or drive to work, will that make their healthcare better? We'll dive into that. We have an excellent guest who I'll introduce in a minute, but first I want to ask Saul, why did we pick this topic?
So I think there's a paradox here. On the one hand, I think it's fantastic that there's been this movement to consider social need. And again, by the way, there's the term social determinants of health. Some people now use the term social drivers of health because, of course, we don't think of them as deterministic factors, but as drivers. So again, we can go back and forth between those two. As I said, on the one hand, I think it's just terrific that there's been an attention that's been given to this. I have to say there's a certain irony about it, because if you look at the definition of social determinants of health, which we'll talk about, it should have sort of been obvious to all of us that being homeless isn't probably good for your health, and being food insecure is probably not good for your health. And so I think there's a certain privilege that is reflected in the fact that someone had to point this out to us collectively, and that all of a sudden we're like, oh my gosh, this is so important. So I just want to point that out. But so on the one hand, I think that's great that now it's being talked about. On the other hand, there's a part of me that has a bit of a concern that this is just going to turn out to be yet another fad. If you think, I've been in medicine for a while now, and I can think of these sort of bandwagons everybody jumps on. For a while, it was medical error, and then evidence-based medicine, and then patient-centered care, and now it's social determinants of health. And is care any more patient-centered now than it was in 2005? I'm not so sure. The other thing is that, as some of you know, the research I do involves listening to thousands of audio recordings of doctor-patient encounters. And we've been doing this for well over 10 years. And unfortunately, we just don't see a lot of change. In fact, we see an increasing kind of standardization that I often refer to the efficient task completer mindset. What I mean by that is a typical audio recording. You hear a doctor just kind of clicking on their computer, looking at their screen, asking the patient, have you had a colonoscopy? When was your last mammogram? Do you want a flu shot? And so forth. And that's just getting, if anything, worse, not better. And
blah, blah, blah.
Yeah, blah, blah. And to me, that's always like a kind of reality check when I look at all these wonderful papers coming out about how we're concerned about all this other stuff. But that's like the reality of the actual visit is the same old, same old. So when I look at papers on interventions to address social determinants of health, there's a lot of them. There's thousands of them, actually, but there's some commonalities. So one thing you typically see is, whether it's with medical students or residents, it's like, okay, we had them do some sort of screening exercise just using a screen. And then we had them do some sort of intervention where they had to use a web resource, like it used to be called Aunt Bertha, or now it's, I think, Find Help, and find resources and then refer the patients to that. And, and that's like, okay, so we've taught them to do that. Now, it's very detached from the reality of the poverty and suffering that these people are experiencing. It just becomes like one more thing we do. There's a way in which we as physicians turn everything into a set of problems, which require some more forms, something you put in the computer, some intervention that involves usually more forms, and then we're done. And I'm thinking of one particular study, and it's typical of a number of them, where I think it was medical students were asked to do this at a major medical center and, on their inpatient rotation. And at the end, they were asked, how did you feel about screening your patients, calling them, following up a couple weeks later? And they were like, it was a lot of work. I don't think this should be mandatory, et cetera, et cetera. It didn't really warm their heart. And that doesn't surprise me. And I fear that that's just going to make things the same as they've always been. And so I think that what's missing here, we should be looking more at ourselves. We're the ones who need to change. We're part of this system that is just running patients through churn, 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 and everything is turned into a part of that. So that is, I think, a key issue that I don't see being addressed for the most part. The other thing, I think, is that we need to interrogate more rigorously what it means to be poor in America. Given that we as a profession have a commitment to facts and information, I think there should be a deeper reflection on how our patients are in the situation they're in, particularly if we're trying to help them. And the credibility that and whether we have credibility when we're essentially using the kind of, I would say, it's almost like throwing crumbs at them, the kind of things we do with the forms that we send out. This is where I'm eager to have this conversation. And one of the things that I'm really excited about is that Emily Murphy, who you're going to introduce, is exemplary of the many physician faculty around the country who are in the trenches trying to figure out how to teach this, how to help medical students and residents get better at this. And one of the things that struck me talking to medical students and residents is some of them are really passionate about this. They really care. They want to make a difference, particularly early on. But I do find that as time goes on, the sort of cynicism sets in with many of them. So anyway, with that, I want to turn it back to Stefan so that you can introduce Emily and we can get started.
So thank you, Saul. I'd like to introduce Dr. Emily Murphy, who is an assistant professor at the Johns Hopkins Hospital and Hopkins Children's Center. She has a body of scholarly work that examines the intersection of clinical reasoning and the social determinants of health across communities. She addresses social needs screenings in several different aspects of her work, particularly in curricula, both in pediatrics and in adult medicine. She's received awards for this, and I'm super happy to have you here, Emily.
It's a pleasure to be here. I'm very excited to have this conversation, and I think it's one that definitely is important to have. I understand people have, passionate feelings about it because I think as physicians, day in and day out, we're working within this system and seeing patients suffering from it. So excited to be here.
So let's start with kind of the basics. What are social determinants of health?
So I'm going to share the World Health Organization definition. It's the conditions in which people are born, grow, live, and age, and the wider set of forces and systems shaping the conditions of daily life. As a med-peds physician, I like the fact that it really speaks to the entire timeline of a patient aging through time. This can be dynamic. The social determinants of health can change at various points in someone's timeline. And these are primarily external forces that we're discussing.
Do you want to give some examples that apply in childhood and adolescence?
One example would be the patient's lived environment. So that can be, the housing that they live in or lack of housing. It can be housing safety. Is there, unsafe lead exposure in the building that they're growing up in? Are there pests or roaches? Is the patient housing insecure? Perhaps we can imagine, a child, a pediatric patient who initially grows up in a fairly financially stable environment, and then around school age, both parents lose their jobs and their lived environment becomes much different, much less stable. There's suddenly housing insecurity. There's financial insecurity. Their health outcomes could significantly change with that external change to their environment.
What do you think are some important social determinants of health when thinking about adults, including women of reproductive age?
We're probably going to talk about this a little bit later, but just to give some kind of universally accepted domains that are seen as important, the ones that now in the inpatient setting we're being asked to prioritize by the Centers for Medicaid and Medicare Services. There are 5 of them. They're food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. And you can imagine that, within each of those domains, there could be subdomains and subcategories as well.
So first of all, those really resonate for me because a lot of my work is with people who are homeless or formerly homeless, and every single one of those things comes up all the time and absolutely affects decisions that we have to make. But I'm curious if you have some examples from your own work as a clinician, like when have you had to take these things into account and actually make a different medical decision because you knew about a social determinant?
Yeah, I think I can, think of several patient examples for each of the categories, but, drawing from my experience as a hospitalist and thinking about discharge planning for a patient, the things that, that go into my planning process change significantly based off of, as you mentioned, housing security. So access to medications, is this patient going to have a safe place to even store their medications moving forward? That is something I take into account in thinking about medication burden and pill burden, the amount of medications that I'm prescribing, the cost of medications. Transportation is another factor as well. Is this patient able to actually make it to their follow-up appointment, either due to physical disability or inability to pay for transportation? In the state that I practice, we have good transportation options, but the application process requires a physical address, which again takes us back to housing insecurity. So a lot of these feed into each other. And as you learn more about gaps in one domain, you see how it trickles down to really all other domains.
I think I could offer an example also from my experience. In Birmingham, Alabama, to get a number of health benefits and also social benefits, you need to have an ID card.
Mhm.
And if you are homeless, you often have been in a situation where you lost your documents. And I listened to a caseworker describe essentially an 8-step process, which involved 3 organizations and in-person appearances at each of those organizations to help a person who was homeless actually retrieve and obtain a working ID card. So even before they could begin certain types of healthcare, they had to go through weeks of guided entry into bureaucracies to go through getting both the card and the money to pay the various fees that were required to secure ID. So no healthcare could occur other than emergencies without that card. And it would be weeks of in-person visits and bureaucracy just to get it. And yet no healthcare could occur otherwise.
Yes, and in one of the sessions that I do with medical students, I have them talk through, for a case patient who is uninsured, the exact steps they would need to go through and what would be necessary for them to be able to obtain a recommended elective procedure, essentially. And after following this really tortuous path to the end, trying to get to this procedure that's recommended for them, the end point is that the patient might not even be able to get the procedure. But I think doing exactly what you described of imagining yourself in the patient's shoes and imagining all of the barriers that have to be, surpassed to be able to get something which we take for granted, I think is a really important exercise and can really change the way that we think about discharging our patients or even, coming up with a follow-up plan for them, whatever the clinical encounter is.
I mean, truly, since these are really tough issues and you sometimes are engaged in them as a clinician, can you tell me if there's been any situation where it's actually been rewarding for you as a doctor to attempt to make a difference on them? Or is this all kind of like, yeah, life sucks. I just really understand much better than everybody else how bad it sucks?
So, to be completely transparent, do I have those days of absolute anger and frustration and sadness? Yes, I was actually just talking to my fiance last night about that and just how demoralizing it can be. But I think that is also where I do find a lot of satisfaction and derive a lot of satisfaction. The other component of sort of my scholarly interest is in clinical reasoning. And I think social determinants of health and these sort of non-clinical factors are often neglected in clinical reasoning. And, I'm happy to talk about that more down the line.
Yeah, let me ask about that here.
Yeah.
So I remember when I was starting in homeless healthcare, I had this kind of conundrum in my head, which was there's something called the standard of care. And then I was altering the decision because often to something that was maybe not quite the standard of care because I wasn't sure that the standard was going to work. So this is a long time ago, but I remember giving people like clonidine patches for their blood pressure because I didn't know where they were going to store things or I didn't think they could remember to take them. And I was like, clonidine patches, that's not really a great medication for blood pressure, even in the late 1990s or early 2000s, but why am I doing this? And I guess I'm wondering, and I thought, oh, wait, so you shouldn't compromise the standard of care for your patient just because they happen to lack a home or have financial insecurity. That's harming the patient. And then another part of me said, wait a second, no, you should change the standard of care for that patient. So what's the right answer here? Are we allowed to change care to something we think is inferior because the patient has a different circumstance?
Yeah, I think that is the core question here, right? And I think these questions come up as I'm teaching medical students and residents as well of, where is that line between having true patient-centered care and coming up with the right plan for the patient directly in front of you and offering suboptimal care. And I think the core part is thinking about what is the patient outcome that we're looking at and what do I genuinely think is going to lead to a better outcome for this patient. I can think of a patient that I saw on the wards who probably had intervenable coronary artery disease. If he went for a left heart cath, they probably would have found disease and they probably would have stented him. But he told me, I am going to be honest with you. He basically described significant social isolation. He hoped to get more supports. We were in active conversation with social work and case management about more supports. But he said, I don't think I'm going to be able to take a medication every day. I was talking to him about DAPT, and he said, I don't think I can do that. I don't want to do that.
Yeah.
And so this is just, one example of the standard of care would have been doing the procedure, putting a stent in, but he would have had likely a very poor outcome and so we listened to the patient. We came up with we asked, how many medications do you think you can take? And he told us 3. And so as a result, we came up with a list of 3 medications that we thought were the most important for him. I think he went out on statin, aspirin, and a beta blocker. And we tried to get him the best possible follow-up to reassess him when he had the social support intact, where maybe he would have a good outcome with the intervention. And so that's just one thought that I have in mind. But I think often we're in these uncomfortable positions where we know what the recommended treatment is, but it's treatment that could potentially cause harm to a patient depending on their life circumstance. And that's where I think the clinical reasoning bit comes in, right? The thought of, maybe the clonidine patch, it's not, in our AHA guidelines, but maybe that is actually what is going to lead to the best clinical outcome for the patient in front of me right now. And I think especially, knowing the data that we have in the United States around, what factors contribute to health outcomes, we need to be teaching medical students and clinicians to be incorporating social drivers of health into their clinical reasoning to make sure that, within the very, very flawed and frustrating limitations of our healthcare system, that we can try to achieve the best feasible outcomes for our patients.
Yeah, I appreciate that. And that overlaps a bit with Saul's research, which may come up later. But I think for our listeners, I want to highlight that we've spoken about, for the last few minutes, about social determinants of health as something that affects clinical decisions we make at the individual level. But when I introduced this, I highlighted, and then you read a definition that highlighted social circumstances that are really quite broad. And healthcare systems are increasingly being asked to detect if there's an adverse social circumstance, whether we call it a determinant or a driver of health, and then somehow intervene on that. And I guess what is it exactly that health systems are moving toward doing at this time? What are these new policies and programs?
Yeah, so I can certainly speak to what we are seeing on the inpatient or in the inpatient setting, which, is new as of this year. So the Centers for Medicare and Medicaid, as of January 1st, 2024, have had a couple of new measures. There are 3 of them that relate to what you're asking. And I'm actually going to talk about measures 2 and 3 first.
Sure.
Because I think it helps. I think going through those 2 measures first kind of lays a foundation for the latter part of your question. So measure 2 and 3 relate to screening for social determinants of health and reporting the positive rate for social drivers of health. Just to add, another set of terminology into the podcast, we've talked about social determinants of health, social drivers of health. Actually, within these measures, the language used is health-related social needs that are being screened for. And so as of January 1st, 2024, there is now a requirement that a hospital screens all inpatients who are 18 years of age or older for 5 health-related social needs. And those were the domains that I named before of food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. And interestingly, related to the fact that this requirement is fairly new, CMS really left it up to the hospitals as to how they screen. They provided some example screening tools, but really how the screening is done, who does it, what specific questions are asked, that's left to the hospitals.
Okay. Is your hospital doing something like that?
We are. So all hospitals are required to, and so
we're all doing it. All right.
Yeah. And so I work, just to name, our workflow, all inpatients at our hospital are screened either through the electronic medical record if they do have a patient portal chart already set up. That's an option at the time of admission. And if not, or if they're unable to complete it, then a community health worker completes it. I do know at a different hospital that I teach at for pediatrics, it's done by nursing within the admission bundle. So there's definitely, I imagine, a good amount of heterogeneity in how this has actually been implemented. So this measure 3 is the actual reporting. And so reporting of the screen positive rate, the reporting is due next May. So it'll be interesting to see once all the reporting is due, the data that comes out of that.
Okay, so first of all, I should mention that I work in the Veterans Administration system, which has had a screener for homelessness at the front end for several years now. And there are a long set of services that the Veterans Administration can offer because the Congress has allocated so much money to address that. But now, if I get outside of my own healthcare system and I think about the standard teaching hospital or community hospital, I get that they can detect these social determinants or drivers or whatever we call them. I get that they can record it. What can they actually do?
So that's why I wanted to describe measure 1 last, because exactly as I just described, measure 2 and 3 relate to doing the screening and reporting the screening, but there aren't any specific requirements to addressing positive screens. What CMS does ask is some sort of reporting of the hospital commitment to health equity. And so this involves, a couple more domains. So they require that health equity is included in the hospital strategic plan, that they're doing some sort of data analysis on their own social determinants of health data, and so stratifying their own performance by the SDOH data. They require to be some sort of quality improvement initiatives in place, but that could really be on any level. And then they also ask that leadership is involved in some way. So, for example, senior leadership reviewing strategic plans, and again, reviewing the performance data. So what is not present is, a mandate that for all patients, who screen positive, there needs to be XYZ intervention. At our hospital, for if a patient screens positive, the community health worker provides them with resources actually through Find Help, which is one of the resources that Saul was mentioning earlier. And if the patient screens positive for interpersonal violence, that leads to a social work consult. But it could be very different within a different hospital system.
Do you want to give the most positive example of a successful action or program by any hospital? It doesn't need to be yours, where you felt like, they're screening and they're doing stuff.
Yeah, there have been several very interesting studies responding to social determinants of health. Just taking housing as an example, there is a study actually out of Chicago looking at a very robust case management and housing program where they compared this post-discharge case management and transitional housing program to standard discharge planning. And they did see a significant decrease in hospitalizations and hospital days, ED visits, post-discharge. Thinking about transportation, there are lots of different non-emergency medical transportation services in the United States, and vary state by state level, but we've seen that allocating those resources to non-emergency medical transportation makes a really big difference. There was a study of Medicaid recipients, and about a quarter of them said that they would die or probably die if they didn't have this non-emergency medical transportation available. So more than half said that they would not actually make it to any of their treatments. So when we have these resources in place, they can make a really big difference for our patients, which is why it's important to screen and identify them.
Yeah, so transportation clearly is one of those things where sometimes a health system can provide it or sometimes they can set it up. I guess the other side of this is that I can imagine and maybe we're going to get to this with Saul, but clearly so many of these things really reflect social policies, collective decisions or non-decisions that occur through society at large, either by history, tradition, the Congress, the state that you're in. I think the National Academies may have had some sort of comment on this.
Yeah, so they've developed a 5 A's framework identifying 5 main activities healthcare, can implement to address social determinants of health and social risk. And those, start at the level of just awareness. So screening, the practices we're talking about right now that now all inpatient health systems are going to be required to do. Assistance, which sounds similar to what Saul was describing, the medical students doing in the beginning of helping patients get social care. They're screening them and then they're giving them resources. They're just, they're handing them papers, they're filling out forms for them. Adjustment is the next level, which is kind of where I'm the most interested. That it's the adjustment phase that is where I like to do all my research. And that's figuring out how we, as physicians, as healthcare providers, adjust our medical care to the patient in front of us. That's where that clinical reasoning comes in, and figuring out what is the best treatment for the patient in front of us. And those first 3 A's are really the levels at which we as providers probably engage for the most part. The next 2 levels are kind of those systems and policy level interventions. So alignment is the next one. And that is, as a healthcare system, let's say we get all of our CMS data. We see that 50% of our patients have transportation insecurity. So we're going to then try to align with social care organizations out in the world. Perhaps, in Maryland, we have the Maryland Transportation Authority and the MTA. They have resources for patients. So maybe our leadership reaches out and says, hey, we'd really like to come up with a more robust transportation program. And that's, again, kind of higher level. That's not me as an individual reaching out to a community health worker, an individual at a community organization. That's really aligning our system with community healthcare organizations. And then that final top level is advocacy. So advocating on the government, on the policy level for really systems-wide change.
So I think that we've kind of put on the table the landscape at present. We haven't gotten into exactly how hospitals code for these things. I think that's okay not to discuss. But, you've sounded a bit skeptical, Saul. Do you want to comment on what you're ruminating on and why we maybe shouldn't take this at face value?
So I want to go to the example that Emily gave, which I thought was excellent, where she was working with this patient who said that having a cardiac procedure wasn't going to be the right fit for them given their social circumstances, and that they couldn't take more than 3 medications. And Emily decided to work with that. And I thought that was beautiful. And to me, that is what I refer to as contextualizing care. As you know, that's been the area that I've been so interested in. And contextualizing care is a 4-step process. It's recognizing clues that a patient has something going on that is directly relevant to planning their care. It's asking about it. It's hearing what's going on and working with them around that, and then coming up with a plan. And to me, that is very much the purview of the clinician. And I think it fits into the clinical decision-making process. It's also a very interpersonal process. It's done in a way that is, I think, on a level playing field where you're working together, you're problem solving, and you have a sense of caring about that person. And I think that's really where doctors should excel. I think that the stuff around screening that CMS requires, and then going to help.com and giving resources, I don't see why doctors should be involved in that. I think that doctors should know what's happening, but I think it's not a good use of their time. And it's kind of bureaucratic. It's important. I don't diminish it. But I think that we need to not push that towards the medical students and the residents, but push it away from them and just make that a systems thing. When we go back to the framework that we're talking about, the National Academy framework we're talking about, what that boils down to is that assistance and adjustment are really in the purview of the clinician. Both of those are things where you're trying to figure out what kind of adjustments should I make to the ideal care plan? What kind of assistance can I make to this patient? And with the assistance, you may outsource that, but you might be the one who initially identifies the need. Alignment and advocacy are those are high-level things, but they get at kind of societal issues. But I really think that we need to think of it that way with medical students in residency. Other thing I want to say is that it's never been clear to me why we just limit this to people with social need. The job of a doctor is to help people who are their patients. And so if a patient comes into you and they've lost control of their diabetes because of a social need, like they're experiencing homelessness, they don't have a place to store their insulin, you want to figure that out and help them. On the other hand, if they have lost control of their diabetes because, they live in the suburbs, they've got a nice home, but their vision's failing, they can't read the bottle, you want to know that too, and you want to help them. If their fingers are getting arthritic and they can't manage the bottle, you want to figure out how to help them with that. And they may not have a social need. And so I think that the point of being a physician is that we're here to problem solve with patients, which can require some form of adjustment, whether it's in the context of a social need or not. And so I think there's something a little bit artificial and odd about how we just kind of set this universe around, people who are struggling with things related to poverty or marginalization. I think really the message for those who are teaching medical students and residents is that this is really part of physicianhood and thinking about breaking away from this efficient task completer mindset where you're just sitting at the computer and you're just trying to chick. Okay, I got to send out this screening thing. I got to give them this form and so forth. That's what we're trying to break out of. I think some of the skepticism I'm expressing is that the system is so unrelentingly profit driven, that the system is so focused on turning us all into this cog. That we really have to be cognizant of the fact that we're being pushed in that direction, and we have to basically push back, take ownership of it, say, no, that's not the kind of doctor I want to be. I want to be a doctor who helps people. I mean, you and I did an episode recently, Stefan, on Matthew Perry, who was super rich. And Matthew Perry was exploited. He was exploited, and he was a victim of people who were taking advantage of his wealth. As you know, this was about ketamine, and he didn't have a doctor who cared about him and was looking out for him. And so I think what I'm saying here is that that's what physicianhood is about, and I think that we should, we should emphasize that. Otherwise, I think our medical students and residents are going to get kind of frustrated and burned out with this whole thing of forms and websites and stuff like that.
So what I hear you saying is that there are some specific kinds of clinical work in which the context really matters, in which those are actually very often driven by a variety of factors, some of which are clearly social. They may be particularly intense with certain poverty populations, but by no means restricted to that. And you're on board fully with us teaching medical students, residents, and other clinicians to focus on that. But you're also kind of raising a flag of concern, at least about how much we as health professionals get involved at the next level. At the level of advocacy and alignment. And actually, are you saying that? Or are you saying, look here, it might be in our lane to understand how my patient stores their gun, but it might not be in my lane for me as a doctor to declare what gun policy should be. Like that's like
I think it's in your lane as a human being, and as a physician, you have a front row seat on the consequences of these policies, or for patients who are harmed. And so I think you have a front row seat, and also you often have maybe more cachet than other people. There's still a fair amount of respect for physicians, and especially because we have this front row seat. And I think if you step up and you become an advocate and try to push for social change, you're probably going to be a very small part of that process. But yeah, that is how you drive change. But I think that I just want to emphasize that that's not with your clinical hat on. I think let's face it, most physicians are pretty busy seeing patients every day, and they may or may not have the skills or the time or the energy to go to Washington or whatever, or to advocate locally. And I think we have to make it very clear that that's wonderful, but that's not what we're expecting of physicians. I think the real problem with physicians right now is not that they aren't all going to Washington and advocating. I think the real problem with physicians is that when they're in the exam room with patients, they have become robots. They're sitting there punching stuff into the computer. They're filling out forms. They're placing orders, and it's disconnected. I mean, I was listening recently to an audio recording where a patient was homeless, and this was actually a third-year resident, and the resident was conscientious, but the resident was just hell-bent on getting through his stuff. He was asking about a colonoscopy, and, the patient was like, well, I'm going to be going into this residential home situation. I don't think I'm going to have an opportunity to have access to a toilet when he heard about the PrEP. And the resident was like, well, yeah, I still think you should get it. And then later on, he was talking about how the patient is obese. It was the term the resident used. And he wanted to refer him to a nutrition program. And the patient made some reference about how, well, I don't have a lot of control over what I eat, where I'm going. And, the resident just kept moving on. Okay, so what about the flu shot? And it was just like this thing. And I was like, that's where we're falling short. That's where the resident has to say, I don't need to worry about the colonoscopy. I don't need to worry about the obesity. I need to turn my chair, face this person, and figure out, wow, so first of all, I'm so glad that you're not going to be living on the streets anymore. By the way, this patient come in with plantar fasciitis, and his main problem was foot pain. And so and there was no conversation.
Incidentally.
Yeah, there was no discussion of what are you, are you on pavement all day? What is your life like? And so it was like, no, I'll just refer you to podiatry. And so I think what I'm saying is that that's where physicians need to do a 180-degree turn. I'm not talking about all physicians. I'm just talking about what we hear typically. And I think that the example of what Emily describes, where she's talking to this patient and saying, okay, I know the typical thing for this person would be to send them for a stent. And I know the typical thing would be to put, but that's not going to work here, because this patient is telling me things I need to talk with them about. To me, that's the essence of what the focus is. And again, not just for patients with social need. It's part of being a doctor. And I think that's the concept of taking patient life context into account, seeing it as a kind of information that's essential to integrate into the other parts of decision-making, which include assessing the patient's clinical state, identifying the appropriate research evidence, knowing what the patient's preferences are. All of these things come together. And that's what doctoring is. And so I think that's the point I would like to make.
Emily, do you have any reactions or responses just to what you heard or questions for Saul? I mean, what do you think so far?
Yeah, I think we're on the same page that, at the core, we need to consider the patient context. When I feel like I am able to adjust my care, and that is something that gives me back some control. When I am taking care of patients in the hospital, whether they were just admitted a week ago, whether they've been admitted, 10 times in the year and are really struggling, my one goal for myself is to do one thing differently for that patient each time when they're hospitalized and try to find one thing, that we can change. And so I think because social determinants of health can sometimes feel so unmovable and very depressing, that's why I think it's important to focus on them and figure out strategies that we as physicians can employ to address them.
Saul, what do you think of that?
I agree with it. I think that the framework I like to evoke is that doctoring is really about just two people sitting together trying to solve the problems that one of them is experiencing, the patient. It's genuinely a problem-solving situation. So you don't have control over the universe that has affected that patient. And I think that universe is often very unjust, particularly in the way we've talked about today in this country. And you may choose to work on that as part of your personal mission. But when you're in that room with that patient, you have to work with what you have. And the best way to do that is through a conversation that is practical and caring. And I like to say loving because I find that word means something to me. And I was thinking, I was in the emergency room. I do fast track at the VA, and I had a patient who is homeless, and he would basically have these corns on his feet. His feet hurt because he had a lot of calluses on his feet. And I remember we're sitting together, and he had his shoe off, and his foot was on my lap, and I was like pushing on the different parts of his underside of his foot, asking him what hurt and what didn't. And we just got into this conversation, and it was really nice. And I felt very caring towards this person. And I felt like this is somebody who's gotten a really, really raw deal. Of course, I referred him to podiatry, and I sent him up to we actually have a homelessness program at our facility. But I really enjoyed this man with his foot on my lap and just thinking about what a privilege it was that I was getting to have this conversation with this person. And I also felt that he had a bit of a respite, that he had this opportunity to feel comfortable, to feel seen, to not have to worry. And to me, that really did feel wonderful. It felt like a privilege. And I think that it's in that type of doctor-patient cave, that world where you're with that person, that you can problem solve and you can deal with whatever's happening and come to some sort of plan ultimately. That's what I'd like to see with
Okay, that's
residents.
the good side here.
Yeah.
Yes.
But I'd like to see that. I find it hard to teach because I find that the residents are just, there's so much in this environment where they just like, okay, but then how am I going to, what about the colonoscopy and what about the...
Yeah, got eight other checklists that have to be filled out.
And what I say to them is, one of the beauties of being a physician is that you have discretion. Your job is to say, I have 20 minutes with this person or 30 minutes.
This is outpatient.
Yeah. What's the most valuable thing I can do with this person at this time? Maybe the colonoscopy can wait. Maybe it's not as important. It's just sitting down and figuring out what's going on with this person. And an example I gave a minute ago, they're trying to get into a program, what's happening with that and so forth. And so I just think that is something that physicians often don't realize is their job. Their job is not to just do cookie cutter medicine. Their job is actually to figure out what's the most valuable way that I can use myself as a resource to this person given the time we have. That is actually what we're supposed to be doing. And we can always document in our note why we didn't get to the other stuff because this thing was more important. And so I think that that's a message that we're not necessarily conveying when we train medical students. And I think is so important. When I tell that to medical students and residents, they're often like, oh, really? I can do that? Like, I don't have to do all this other stuff? And I'll be like, yeah, of course. And it's very liberating for them because then they can start to be a full person with that person. And also I encourage them to not feel like they're interchangeable with every other doctor. Like figure out, be who you are with people. And when we talk about social determinants of health and curriculum, it's so far away from all of this. It's all about these policies and procedures and forms and stuff like that. And I think that creates it sort of sanitizes it. It integrates it into sort of the monster that we've created that we call the healthcare medical industrial complex. Monster. This whole idea that we're just cogs in this huge system that's pushing patients through. And we give lip service to it by, and I'm not saying we don't help some patients with these forms and these interventions. I'm just saying that may not be the doctor's role. And what's critical, what the doctor needs to do is focus on that relationship.
I have to ask, is there any line of tension between what you've just said and what Emily's been teaching us about through this session? Or are you guys
No,
basically in agreement?
I think Emily practices that way. And I think
I want to ask Emily,
yeah, okay. Well,
not
I'm
you.
just giving you, well, but no, she may be too humble to say that. She may be like, she may be humble to say that. But I'm just saying what I'm hearing from her and the example she gives is an example of that. But I also think that she's describing processes that are coming from CMS and others and so forth that kind of reflect what I'm talking about, where like, it's like, oh, you got to do this, but we don't really need you to tell us whether you're going to use the information for anything.
I think, something interesting is that, what you're describing, Saul, is aligned with what the ACGME says that graduating residents should be doing, or the Accreditation Council for Graduate Medical Education, and their milestones for a graduating resident. It isn't, complete social determinants of health screening form. It's developing a comprehensive plan that incorporates psychosocial and other determinants of health. It's,
okay.
That's is, good. And whether or not, our education is aligned with those goals is a different question. And
I mean, one thing to pick up on what you're saying, one thing that I have found with often very smart residents is they'll present a patient to me. Let's say it's an older man who has fallen a couple of times. He's hurt himself. He's come in. He's a little confused and so forth. And I'll say, who's he living with? Is he living by himself? And they'll say, I don't know. And again, this happens all the time. And to me, I don't mean to be harsh, but it's hard for me to conceive not knowing or wanting to ask that, because when I think about a patient coming in who is a little confused, who's falling or whatever, the first thing that I'm trying to do is picture like, who's in this person's life? What's happening? I'm trying to think about this person out there who's tenuous, who has poor balance. Like immediately, that's the first thing I think of. And when I listen to recordings, I see that problem over and over again. So I think that, it's great that a guideline says, or ACGME says we should be doing that, but there's a chasm between that and what's happening. Because when our medical students or residents are learning on the wards and they're getting to their medical records and they're having to write their notes, they don't get credit for that. And they do get expected to check off the clinical reminders and all that stuff. And so that's what I see. And also the other thing, and this is just more intuition, I feel like a lot of our trainees are uncomfortable or aren't sure how to have those kinds of relationships with patients.
Yeah.
And they just don't know how to do it. And so that they inadvertently hold the patient at arm's length and they focus on tasks. And so that's, I think, something that requires changes within us. And it doesn't happen easily.
I hope this doesn't seem too far astray, but you kind of said you're not expecting every doctor to become, I guess, a political advocate as part of their identity as a doctor. And yet there is a kind of public discourse out there where there are organizations and op-ed saying, that we are training a generation of medical students to be social justice advocates, that we're telling them to take some position on an issue relevant to health, often on the left side of the political spectrum. And I feel like we have to at least acknowledge that there is this accusation. There's like loads of op-eds. If you read the Wall Street Journal, you would think it's true. Let me just say that. First of all, is that a cartoon about about what's going on, or is it also true?
Well, let me speak about my own personal development on this. So when I was a medical student, we had one of those free clinics where you could go and volunteer. And you felt good about it. You're like helping people who are coming in and so forth. And then later on in life, I started to, aware of the way in which there are so many people who have high level of need. It's not just the ones who show up. There's a high level of food insecurity and high level housing insecurity and so forth. And so just this whole idea of scarcity. We just don't have enough to go around and so on and so forth. And I think what has changed my thinking has been some of the work of some of the major scholars in this area, who I think are very evidence-based. And one of them is Matthew Desmond, who's wrote Evicted, and then he wrote Poverty by America. And he asks the basic question of like, why is poverty getting any better? Why is it 10 to 13%? And that was true in the 1970s, 80s, 90s. It hasn't changed, even though we're getting a lot wealthier. And he says, that's the question. And why is it that it's so much worse in other countries that don't have as much money as ours? Why is it that we spend so much on healthcare compared to other countries? And yet we have far worse access. And what Matthew Desmond concludes, and I think it's backed up with an enormous amount of public data, is it's not an accident. There are many ways in which we profit from having a highly vulnerable group of people. And by the way, he quotes Tolstoy, who talked about this when he moved to Moscow and noticed that amidst all this wealth, there was an enormous amount of poverty. And Tolstoy is very wealthy. And he just said, wait a minute, like these people are poor because we're sitting on their neck, and we got to stop sitting on their neck, and rather than saying, oh, I want to help the poor. I don't think Matthew Desmond is an ideologue. I think he shares a lot of public data and shows in dozens of ways how we profit from poverty in America, and how it's not just an American thing. It's in every society, there's been ways to profit from people who are poor because they're vulnerable. You can exploit them. It keeps prices down. And that is something that I think, for me as a physician, it does shape my mindset. When I'm with a patient and they're homeless and I see this person as somebody who is being screwed rather than as somebody who is a little lazy, has addiction problems, or, ended up at the bottom because we don't have enough to go around. I think it's different for me when I recognize all the ways that this person is being beaten down. It's helpful for me. It makes me much less judgmental. And also it makes me aware that if I want to help this person, I'm helping them against incredible odds. And that relationship with me is going to be very important. I can be that rock in their life. I'm not a social worker, but I can be the person who is there, who can help them just by letting them know that I see that this is tough and that I'm there as an ally. And so I do think that mindset for me comes from the understanding I have of the way in which our system is beating them down. And so that's how it's been valuable for me.
I agree. And I think something that's always mind-blowing to students as well when I'm teaching them is I think this also helps them get away from I can just refer them to something and be done. And actually talking through what the benefits of some of these programs that we're referring to patients look like, they're often very shocked by how limited the resources actually are. I ask them, how much do you think the average monthly benefit for, a single income beneficiary of SNAP, the Supplemental Nutrition Assistance Program, is? And it's just over, $180. That was the most recent number that I saw, which, imagining over the course of a month is not necessarily that much, especially if somebody might be in a food desert. And so I think that also gets us away from okay, I can just refer and be done, and more of the mindset of I need to get to know this person and see where they're at and try to come up with a plan that works for them. It's not just, a referral and be done. I think to the question too of, do we as a society or as a medical society, are we all needing to go into advocacy? Something interesting as I was going through all of the AAMC competencies is that one of them does say, demonstrate accountability to patients and society. So that is something that is embedded in the expectations for a graduating medical student, that there is that accountability, not just to the patient in front of you, but to society as a whole. And I do think it's we're in a sad place where the idea that each person in front of us should deserve housing and should be able to have housing is, a radical idea. I agree completely with Saul that I think if you are spending time with a wide variety of patients and getting to know them as people, it's hard to imagine that is something that should not be available to everyone, these really basic human rights.
Let me contest that, but only for the reason of trying to understand whether I can take good care of my patients if I don't agree with you. So, Saul, first of all, for anybody who doesn't know me, I revere people like Matthew Desmond, but the idea of a poverty rate counted in the way that he uses in his book is not necessarily the only way to measure poverty. There are scholars who've issued alternative measures that look at how much people consume actually using national consumer surveys as opposed to their personal income. And then they incorporate into that transfers of income that are not often included in the poverty measures, such as SNAP benefits. It turns out the poverty's gone down. I'm not saying that I have resolved this economic debate in my mind, although I'm happy to hear an argument against it. But if I were to take that up and say, look, I don't agree with you politically. I think Matthew Desmond's a wonderful guy, but I have a different understanding of the progress of American society and poverty. Is there any implication that I would not be able to make sense of how to take good care of my patients and fulfill my obligations as a doctor?
I think the fact that we have so much poverty in this country is a fact. That we have a lot of poverty in this country. We have a lot of people who are food insecure and homeless and so forth. I think the fact that, as Desmond puts it, we have over $1 trillion a year of uncollected taxes from people in the top 1 or 2%. that they're legally supposed to be paying, and that you could raise everybody up to the poverty level for $170 billion. The list goes on and on. I think the point is that people can go form their own opinions, but I don't think this is ideological. To get to your second question, I do think that you could be a person anywhere on the spectrum and be a wonderful physician in caring for patients if you just focus on the fact that good doctoring is about sitting down together and problem solving, figuring out what's going on with that person and how you can help them troubleshoot whatever in their life is affecting their ability to manage their care. And I don't think that where you are on the political spectrum is necessary or relevant to doing that well. And I think, unfortunately, a lot of us who are on all places in the political spectrum have a lot of room for improvement.
I mean, I personally agree with you. I wanted to make sure we expose that issue because it's such a hot topic. There are whole organizations dedicated to contesting how politics gets into our heads or into our discourse. So let me say, Saul, I think I agree with you and I'm good with you. Emily, do you have any final thoughts at this point?
I think my final thoughts are that, Saul, I think that we're really in agreement if we look at the core of what both of us, is espousing and believes in. Both of us believe that we need to be spending time with patients. We need to be considering the full context of their health beyond just the medical facts. I think that we both agree that social determinants of health, these, structural factors that are to some degree not significantly modifiable, significantly impact patient outcomes and also impact, I think, us as physicians too, and having feelings of helplessness as we go to work. I think we're in agreement that this is, a major issue for our patients and for our health system right now, and that the best way to tackle this is by taking them into account, taking patient preferences into account, and coming up with the best plan that fits the patient in front of you.
Thank you, Emily. I think that's a nice way to wrap it up. And I do think that, again, to summarize this one take-home message, really the focus is on going back to the doctor-patient relationship, recognizing that with any patient, whether they're dealing with a social need or whether it's some other issue in their life, if you can become somebody and continually grow to be somebody who has these partnerships with patients, finds joy in it, I think that's going to be an answer to the moral injury. It's going to be the answer to burnout, at least in part, not entirely, and it's the most powerful way, in my view, to address some of these challenges. So yeah, thank you, Emily.
Thank you, Emily. Thank you, Saul.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.